By request of the meeting organizer, this meeting is being recorded.
With the National Quality Center, I am the Manager of Technical Assistance and Dissemination, and I am really happy to welcome you to today's End Disparities Learning Exchange webinar, Working Together as a Community to End Disparities. We have a number of community presentations today to help us work through what it takes to work as a team to end disparities, and we're really excited to bring this program to you today. So before we start, we'd love to invite you to enter some information about yourself in the chat room if you're connected to the online portal. If not, then we're still interested in who you are and your participation, but we won't have a way to collect that. This will just give us a little bit of a sense of who's calling in from where, and you know, help us get to know each other just a little bit better. And just some ground rules for today's webinar. We invite you to actively participate in today's webinar by using the chat room. There are going to be a couple opportunities for us to interact with each other. We'll open the lines at the end for our discussion. We'll ask that you don't put us on hold. One of the main reasons why we do put everyone on mute on entry is just in case there's some excitement in your office, an ambulance going by, or a dog barking if you're working from home. But also many of us have some groovy on-hold music that, you know, can be a distraction if we're unmuting the lines for discussion at the end. So please do avoid putting us on hold and use your mute button locally if that works for you. You'll notice that if you're logged on to today's webinar presentation, there is an orange button to the right of your name. You can click that button to unmute your line, and then you can re-click it to mute your line. At this time, I just want to check to see if Nanette Bray-Magnani can hear me. I believe I've unmuted your line.
Yes, Michael, I can. Thank you. I'm sorry. I just, the password and the registration ID numbers aren't working for me.
That sounds familiar. We've heard a number of issues around that today, and for those of you who are logged in, you'll see a big old string of guests that are logged in. These are folks who were gracious enough to join us, even though they were frustrated by the system, and thank you to each of you for joining us. An announcement from us at the End Disparities Learning Exchange: we are going to be moving from this training environment into a new environment that doesn't require registration for the next webinar. You'll receive a notice from me within the next couple of days telling you how to manage your registration. I know that a couple of you have already registered for January webinar and beyond, but we just want to make sure that you're comfortable and understand that this change is just to make your experience a little bit easier, and we appreciate all the complaints that we've heard from folks who have tried to join these webinars and have issues. At the end of today's webinar, you'll notice that you'll get an email for a evaluation. We strongly encourage you to help us complete that. It's really important to make sure that we are providing the best possible material to you through these types of experiences. So at this time, I'd like to introduce to you my boss, Clemens Steinbach. He'd like to provide some words of welcome to all of you today for joining today's call. Clemens?
This is Clemens Steinbach, and I want to extend a warm welcome to all of you. I'm excited to have so many of you on the call today. When we started in October, we really wanted to introduce the idea of end disparities to all of you. And in November, we focused on the tools and resources available to you, really to work on as an individual agency. And I think today, it's very appropriate how we as a community can make a difference. And so we are very excited to have two wonderful presentations from two sites that I was able to visit over the last year, one in Rochester with Shirley and Kim, as well as we have our colleagues in Cleveland with Kate and Melissa. So we are very excited to have you on the call today. We were looking forward to hear your wonderful stories about how you have tried to really work not only as a single entity, but one that really represents the community. We're looking forward to listen to you, and again, I would welcome all of you to participate actively. Use the chat room, use your questions. We have multiple folks here that really try to go through the question you're posing in the chat room. And so I want to thank all of our presenters and the rest of the community to really be part of our call today. It is my true pleasure to introduce Jeb. She's our new project officer at NQC, and I will turn it over to you, Jeb. And I would love for some opening remarks on your end before we get going with our important webinar today. So hi, Jeb, and we are looking forward to hear from you.
Thank you very much, Clemens. I'm Jeb Martin. I'm new to Hub and HARSA. I took over from Emily, who has been running this project on behalf of the Bureau, and I'm just really thrilled to be part of NQC and all the great work they're doing. I come in with experience from the inpatient, and not only was I an inpatient nurse, but I also did quality for the inpatient setting. And just being part of the Disparities Learning Exchange has been really an opportunity to learn what the community is doing. So I'm glad to be part of this team, and as I continue to learn, we'll be able to exchange some ideas as we continue doing this together. Thank you.
All right. Thank you so much, Shep and Clemens, for your words of welcome. For those of you who might be joining us for the first time or who are watching a recording for the first time, some background. The EndDisparities Learning Exchange is a 9-month initiative that promotes the application of improvement interventions to reduce HIV-related disparities in 4 key subpopulations while building and sustaining a community of learners among Ryan-White HIV/AIDS program recipients. The Learning Exchange offers informational opportunities by content experts and utilizes the power of peer learning to facilitate local improvement efforts on eliminating HIV-related disparities, and today's webinar is one such opportunity. We also have calls that are designed for consumers called Partners in Care webinars, and we also have office hours on Fridays that are informal discussions that rotate around our topic of the month. And you may have gathered that the topic for this month is working together as a team. During tomorrow's office hours with one of our coaches, Judy Popkin, I'll be exploring our NQC Share Lab and providing an overview of how to use this tool, how to register for the tool, and how to share your own awesome projects through this great social media platform around quality improvement. NQC is a technical assistance center funded by HRSA-HAB to provide a number of levels of technical assistance to the Ryan-White HIV/AIDS program community. This community of learning is one of our big activities, but we also provide a lot of niche one-on-one activities should your agency require or be in need of one-on-one coaching or technical assistance. And in addition, we offer customized and standing single to 3-day trainings for Ryan-White HIV/AIDS program teams. For today's agenda, we're working our way now through the welcome and introductions. We're going to have a discussion on community efforts to end disparities, and then we're going to have 2 presentations from Ryan-White HIV/AIDS program recipients in the community, the Cuyahoga TGA, Part A, and the McPeak, which is a group of Part C and D clinics linked together in Western New York. We'll wrap up with a Q&A session where we hope that you'll take advantage of these great presenters and all of our focus on this important topic of working together as a community. Some learning objectives include listing who should be involved in helping to solve disparity issues, describing the principles of stakeholder engagement as it relates to community team building, listing strategies that maintain team focus on the collective QI project. So at this point, it's my pleasure to turn things over to Nanette Bray-Magnani, who is a friend and a colleague here at the National Quality Center. She has been involved in National Quality Center work since before we were even the National Quality Center, and she's worked with a great number of Ryan-White HIV/AIDS program recipients across the country. Right now, her focus is mostly on Western New York, Mississippi, the greater Chicago area, Eastern Pennsylvania, Louisiana, Massachusetts, and Connecticut, Rhode Island, Vermont, New Hampshire, and Maine. So she is a very busy woman, and we're very, very, very happy to have her with us today to help us lead this conversation on working as a community. Nanette, I can advance slides at your command, so just let me know when you're ready to move to the next slide, my friend.
Michael, I have to apologize. Since I can't get in, I can't see the slides. Would you mind quickly sending them to me, and I could download them and do that by not via the webinar?
Absolutely, that would be my pleasure. And thanks so much for your patience as we dealt with our technical difficulties. You'll find that link in your email directly.
Great. I tried Google Chrome and Safari. Neither one of them worked.
Yeah. Thanks for your patience. Again, this is one of the reasons why we're going to be moving to a different platform that doesn't have all this confusion and mess. And thanks to everyone who's bared with us as we've worked through this problem.
Okay.
And currently, Nanette, we are on slide 9.
And I am just opening them up, Michael. Thank you so much for sending them. That was very efficient, by the way.
It's my pleasure. I try to be efficient when we're off-site.
Okay. So slide 9.
Yes, ma'am.
So I think this first question, when we're talking about working as a community, if you can go on to the next slide, Michael, slide number 10, is that obviously everybody can define community based on what your own set of circumstances are. So, for example, you could define it as a Ryan White community. You could define it as a community comprised of Part C's and D's. It could be a community of a Part D network. It could be your whole state, or it could be your EMA. So I think it's important for folks that who are going to be taking a look at it and wanting to do a community approach to ending disparities is to first define what you think your community is. And once you do that, stretch yourself a bit further so that you can ask those questions that are down below, that is there a role for supportive services, and are they within your Ryan White community, or might they be external to it and supported? If you're a Part C, they might be supported by a Part B, so that you're looking to go beyond your own agency, but to pull people together who have the same goal in mind, and that is to work with Ryan White or work with HIV-positive patients, and in this case, to really want to work towards mitigating or eliminating those disparities. The second question there is, what role do consumers have? And ensure that you have consumers, and if possible, right in the beginning, in terms of helping you make those decisions as to who might be involved and who might they outreach to, since they might have more agencies that might be interested. And what role do non-traditional partners have? We know that in many communities, places of worship have taken on a role. Some of them are more traditional, but others have taken on a role to try to help do something and be part of ending the HIV epidemic. And so I'm most familiar with the program that Michael mentioned, McPeak. When they got formed, they really extended the invitation to a wide range of stakeholders. So they may be defining their community a little bit differently than our other presenters today. Okay, the next slide. Next slide, Michael.
Oh, there we go. We are now on slide 11.
Oh, sorry. So this is a recap of December 2nd office hours?
Yeah, I think that one of the things that was important to me, or that kind of stood out from our discussion with folks who tuned into the December 2nd office hours, was that folks are interested in organizing in a number of different ways. Some folks are interested in, working with, if I'm a Part A or a Part B, I'm interested in working with my entire set of networked providers. Other folks are interested more in just kind of linking together across their friendly neighborhood community health centers to create teams like that. And then the last type of team that I heard were teams across the hospital system, so within a single agency, but really trying to link together the folks that are a part of that agency. And in terms of, thinking about who gets involved, all those points that you had mentioned, Nanette, were folks that the people on the call had been expressing their interest in having joined them. So the outside case management agency, or sets of consumers, or places of worship, or other non-traditional providers where you might end up finding folks, housing programs, other food programs, et cetera. So, as far as the community and our efforts are already concerned from folks that dialed in on December 2nd, it sounded like folks are really heading a lot in those directions. And, really what we need is some inspiration, I suppose, or some dialogue around how to actually engage some of those folks in an environment where we're competing for resources, or in an environment where we're competing for patients. Like, how do we work toward that greater good and that greater goal? That was one of the questions I heard, among others. So that's just kind of like my sense. I don't know if you have anything that kind of stood out for you from the December 2nd office hours that you wanted to share.
No, I think, Michael, I think you covered it very well. And so given that the ways in which we traditionally define community or team, I think the presenters today will challenge how we define them. And I think a good dialogue and questions can then ensue from the folks that have joined the call as to really how do they make this work. So with that, the next slide, please, Michael.
Absolutely. We're now on slide 12.
I'd like to introduce Kim Smith, who is from Monroe County Department of Public Health, who was the lead organizer in the group that you're going to hear about today called McPeak, which is Monroe County Partnering to End the Epidemic. And then Kim will introduce the other members of the group who are also on the call today during her remarks. So Kim, please take it from here.
Great, thanks, Nanette. So good afternoon, everyone. I'm Kim Smith from Monroe County. Can we go to the next slide?
Slide 13.
Great. So Monroe County Partnering to End the Epidemic, McPeak, is a non-funded community initiative. Although some of our partners do receive Part C and D of Ryan White funds, we were established to create a jurisdictional approach and response to the mission of two major New York State initiatives, New York Links and Ending the Epidemic by 2020. So McPeak's mission is to end the HIV/AIDS epidemic in Monroe County by 2020 through the development of countywide partnerships of HIV clinical and non-clinical service providers, consumers, and networks who have committed to specific objectives and activities that align with the New York State End the Epidemic initiative. Next slide.
Slide 14.
So McPeak has an initiative structure that includes a management team with responsibilities that include strategic planning, community cohesiveness, mission progression, and ensuring that each McPeak partner has an agency commitment plan that progresses and contributes to the McPeak mission. Our technical advisor, Nanette, who you just heard from, works closely with the management team and is responsible for ensuring that quality improvement is an integral part of McPeak. It is integral to our processes, our objectives, as well as our activities. The work of the management team is then presented to the core team. That core team is comprised of a consumer, clinical, and non-clinical organizations, and the core team fine-tunes all ideas and plans before they are presented to the collective. Next slide.
Slide 15.
So these are the specific agencies, clinical and non-clinical, consumers, and networks that are mentioned within the McPeak mission. So these McPeak partners make up the McPeak Collective. The collective meets every 2 months, and during these collective meetings, agencies share their individual commitment to ending the epidemic, communicate and identify barriers, exchange relevant information, and most importantly, we vote on items that impact McPeak objectives and activities. Next slide, please, Michael.
Slide 16.
All right. So here you have the McPeak objectives. So each objective is accompanied by various activities that assist with meeting the overall goal. So for the sake of time, those activities are not listed here, as there are many. And as you individually read through each objective, you should note that each of the first 6 aligns with New York Links, the New York State ETE, as well as the New York State Care Cascade. Then you have number 7, which was added because as a community, we felt we would be remiss in ending the epidemic if we did not include our clinical trials research. So I want to also give special attention to objective number 5. So this is the primary reason for our participation in this webinar today. So on October 20th, myself and Shari, who you will hear from next, were on the NQC's EndDisparities webinar. So during our October 27th collective, after our technical advisor, Nanette, informed us of a viral suppression contest, and Shari and I updated the collective on the EndDisparities webinar, there was a group decision to participate in both the viral load suppression contest as well as this EndDisparities initiative, and we wanted to do both simultaneously. So being the data-driven statistical guru that she is, Shari agreed to take the lead and collect some information in order to move the group forward. And hopefully you'll also hear from Chantrell and Ashley, who are on the line, and also with 2 of our clinical organizations who are very vested in our McPeak processes, both the viral load contest as well as ending disparities. So on November 27th, during that collective, information was presented back to the group, and the collective began its decision-making process on how to move forward with ending disparities. Next slide.
Slide 17.
So this is where I want Shari, if you can jump in and take it from here.
Oh, hello. Hi.
You're on.
Hello. You're there.
Hi. So thank you, Kim, for that awesome introduction. I don't think I've ever been called a statistical guru ever before this. So I can jump in. So we're on, so if we can actually let's stay on the slide. So as Kim just said, Chantrell Miles from Anthony Jordan Infectious Disease and Ashley Hahn from Unity Infectious Disease, we all got on a call and decided that we would share de-identified data about our patients and their viral suppression rates, and also include information about age, race, ethnicity, gender, and sexual orientation. And that I was going to take that data and do some analysis on it to determine if there were any disparities. So we kind of combined our data and called this is as close as we could get to current data for Monroe County and the McPeak program. So if we can go to the next slide, number 18. This is the number of patients that each organization contributed. So you can see Trillium Health represents kind of a big portion of this. So in a lot of the data that you'll see, just keep in mind the distribution of patients based on the different organizations is kind of affected by the number of patients that each organization sort of contributed to this data dump. And if we can go on to slide 19. Now we're looking at, so we kind of pulled all this data together and just did some initial demographic analysis just to understand if in contributing data from just these 3 organizations, understanding that we're missing a lot of patients in Monroe County who are getting care from other organizations who wanted to contribute data, but were kind of unable to do so on the time frame that McPeak needed it to be contributed. You can see that compared to data from the CDC Atlas, we've got sort of very similar demographics regarding people who are living with HIV in Monroe County. So from the CDC Atlas data, about 42% of individuals in Monroe County are Black and African American and living with HIV, and our data represents about 44%. Our data shows 46% white. The CDC data was reporting 33% white. The one thing to remember is that all of the data from the CDC is from 2013, so it's about 3 years old. So if we look at the next slide, so this is slide 20. You can see that overall gender distribution compared to the CDC Atlas data in 2013 is about the same. Actually, it's exactly the same, just kind of freaky. And then if we kind of go on to slide 21, now I'm not comparing to the CDC data anymore, so we just use those two data points to say, okay, I think the McPeak data is a pretty good proxy for, or pretty good representation of data for people living in Monroe County. Then we can look at the overall demographics just of the McPeak data now. So as you can see here, about half of the patients in our data pool are between the ages of 36 and 55. So that's our largest group. Most of the people in our pool of data are not Hispanic, so 82% are not Hispanic and 16% are Hispanic or Latino. And as far as sexual orientation, almost half of the individuals in this pool consider themselves straight, and 39 report being lesbian or gay, and 4% are bisexual. And then 72% of them, as I showed before, are male, and 28% are female. So that's kind of the demographic distribution of people in our data pool. So if we go to slide 22 now we start to kind of look at the meat of the data. So what this is percent viral suppression by different demographic groupings. So we're looking at the entire McPeak data pool. And if we just look at viral suppression of the entire pool, that's the black bar that's all the way on the left, and you'll see that our overall suppression in the McPeak data group is about 85%. And then you can kind of look at all these different bars and see all of the different demographic groups and what their viral load suppression are. So if I just start from the left and move to the right, that first kind of brown-colored bar, set of brown-colored bars are by age. So we can see that our 18 to 35-year-olds have the lowest rate of viral suppression, and our highest group is our over 55 group. If we look at the orange bar, now we're comparing Hispanic Latino individuals to non-Hispanic Latinos. And then you can see, moving to the purple bars, females are quite low at 79% compared to males at 87%. Our pink bars are LGB and straight individuals, so we actually kind of see a flip-flop of what we expect from the national data, which is that our LGB patients are doing very well compared to our straight patients. And then if we go over to our Black African-American patients, consistent with sort of national trends, our Black African-American patients are not doing well compared to our white patients in terms of viral load suppression, so they're at 79%. So then we can kind of break down our demographic groups even further, and that's the second set of bars there. And we kind of identified, so our lowest performing is a bad word, but our groups with the lowest viral load suppression rates were young individuals, females, and Black African Americans. You can see that of Black African Americans females are doing worse than Black African American males. And so that's kind of all of the data that was.
Please record your message. When you have finished recording, you may hang up or press 1 for more options.
Sorry about that. Hold on just a moment, and I will find out where that is from. In the meantime,
well, they're really tired of hearing me drone on about these bars.
In the meantime, Shalri, we have had some questions in the chat room. I see that Chantrell has already answered the question about viral suppression, but maybe we could talk about that on the line. Also, Alicia had asked, were you able to include transgender patients in your data analysis?
So we did not. So that's a great question. There are so many demographic groups that we could have included, and we didn't include transgender patients in this analysis. I know Trillium could have contributed, but we tried to use demographic groupings that would be available to all organizations. So these are all FQHC groupings for demographics. And transgender and sexual orientation was one that we definitely had. Transgender, I know FQHCs are going to be required to do that next year, but not this year. It's a great question, though.
And Jenna had a question about cross-tabbing demographic groups. In other words, like putting groups together. The example she gave was transgender youth. And yeah, I think that you had mentioned something around the lines of young African-American women doing worse, or African-American women having
African-American females. So yeah, so as you look down into each demographic group, so you're saying like, okay, females, let's look at all the different groups of females and see where the disparities are within females. Your N starts to get very low. So then you start to get kind of into smaller and smaller groups of people, at which point, as you know, the statistics in terms of what really is a disparity or not starts to get a little fuzzy. So if you're comparing 10 people versus 20, and the percent viral suppression is very different, that's not necessarily what we consider statistically significant. All of the differences that I've shown you here are considered statistically significant differences, and we use the Disparities Calculator on the NQC site to kind of confirm that. Thank you, Chantrell, for answering those questions. I didn't even see them. I was too busy talking about the bars.
No, it's great. It takes a team, right? So thank you.
So that's where we ended up, and I think Kim's going to get back on after I'm done talking numbers to explain sort of where McPeak took all this data. But if you want to go to the next slide, slide 23. This is where we do kind of dive down into the female patient groups, where we're kind of looking at the racial distribution within female patients, just to say, all right, so who's in our female patient group? So they're 58% Black African Americans, 87% straight, and 58% ages between 36 and 55. So that top bar is racial distribution within the entire group of female patients. And when you look down at the second row of pie charts, that's distributions within unsuppressed patients. So if we just take the unsuppressed female patients and look at the racial distribution, they are predominantly Black and African American. They're predominantly straight, and they continue to be predominantly 36 to 55. But you'll kind of see what we already had showed before in the bar graphs was that there's kind of a larger number of Black African American women who are unsuppressed when you compare it to the total population. So then, if you want to go to slide 24, this is where I think the Disparities Calculator, thank you, Michael, for providing that to us, where I could edit the different groups. For those of you on the line who have taken a look at the Disparity Calculator, the groupings that are under that first, if you kind of look on the left, it says aggregated data for disparities analysis and the total. The groupings that I've put here are the groupings that we noted had sort of disparate viral load suppression rates compared to the total patient population. These aren't the same ones that are in the Disparity Calculator. You can change these. Actually, I don't know if you can change them online, but when Michael provided this to us, we could change kind of what those categories were, put the data in for each of those groups, and just kind of confirm, is there or isn't there a disparity. And I did put in one group where we had sort of looked at the data and said, all right, I don't think there's a disparity here, and that's the Hispanic and Latino group. So I kind of put that in there just to illustrate how that would come up as what that would look like as being no disparity compared to the other groups.
Cool, and just thank you so much for sharing that, Shalri. For anyone else who's interested in looking at an unlocked version of the Disparity Calculator where you can plug and play your own demographic group, so you can email me. Let me enter my email in the chat room here. It is michael@nationalqualitycenter.org, and I'll be happy to provide you with that tool.
Yeah, and if you want to go to slide 25, just for more numbers, because you know I just can't stand it, right? So when we do dive into the female patient groups, I had sort of said that the sexual orientation between unsuppressed females and the age with unsuppressed females wasn't much different compared to sexual orientation. You can, again, even take those even more dive down categories, enter them into the disparity calculator and confirm, right? There's no disparity between suppression of females who are straight or LGB or within age, but there is a disparity when you look at unsuppressed females in terms of race.
So there was a question from Christine Kibui from California. She said, is your LGB population mostly gay MSM? If so, is that true for all races and ages too?
That's a great question. I would have to confirm that with the data, and Ashley and Chantrell, if you want to chime in on your thoughts on this, I can tell you that what I think the answer is yes. Most of the LGB population is men who identify as gay. So I can kind of speak to that for the 800 trillion patients.
I can confirm that for the 190 Jordan Health patients that, yes, it's the same, mostly gay MSM.
It's the same for Unity, too. Maybe had one person who identified as bisexual, but anybody else in the LGB population classified as gay.
Great. Thank you so much for answering that question. And for those of you who are messaging me privately about the disparity tool, I am taking note of that, and I will be sending it to you tomorrow when I return to my office, because as a reminder, I'm off-site today.
I think then I can turn it back to Kim.
All right. Slide 26.
Yep.
All right. So as mentioned earlier, all of this has happened within McPeak over the course of 2 McPeak meetings in which each discussion was about 30 minutes in length. So there will certainly be more info to come. So this, in summary, reflects where we are now. So as a collective, based on the information provided to us from Shari, the collective agrees that there needs to be a focus on women between the ages of 36 and 55 years old, whereas Trillium also wants to look at African American women specifically. Now, the one piece of information of data that I don't believe Shari showed here, but what we will pay more attention to during our next McPeak Collective is the actual, I think she did a statistical analysis looking at how much of an impact we will make on viral suppression via focusing on African American women. You didn't present that slide here, did you, Shari?
I didn't put it in there because I know the group had focused on a larger population of women, but I think it's important to kind of point out that if you do go after a subgroup like that, in our case, even women or African American women, the impact on your total clinic viral load suppression rate can be very small. So you can improve your African American viral load suppression rate by, you know, I'm going to say this wrong. So if it goes from 80 to 85%, it seems like a big jump, but your clinic-wide, because that population is pretty small, your clinic-wide viral load suppression rate won't go up but 1 or 2 percentage points. But that increase is still an important one for us to make.
I completely agree. And just to piggyback on that, so it's also important to remember that we do have viral load suppression as one of our overall McPeak objectives, and there are very specific activities that go along with viral suppression. So we will be focusing on total HIV population, but then for the purpose of these 2 projects, the viral load suppression contest and then this EndDisparities, we do want to focus on a subgroup. So again, this discussion will be continued in our next collective meeting. And Chantrell and Ashley, did you have anything that you wanted to add?
Hi, this is Chantrell. I just wanted to note that I'm just really excited as part of the collective that we were able to get within, a couple weeks, 3 agencies that are essentially competition to each other across the Rochester area to put their data together in order to, do something positive for the community. So I just think it's really exciting, and for, other areas across the United States to really think about partnering with other agencies in your community to work on projects like this.
And Chantrell.
Okay, thank you, Kim, Chantrell, Shari, and Ashley.
Yes.
Michael, back to you.
Thank you so much, everyone. As Marlene pointed out in the chat room, you did a good amount of work very quickly, and you definitely deserve some applause for that. And I hope that when we get into our discussion later on, folks will have some questions for you, or maybe we can think about some other regions in the country and what we can do in those areas to put together a collective that's kind of like yours.
Thank you guys for having us, Michael.
It's my pleasure. So at this time, unfortunately, we don't have Kate Burnett from Cuyahoga County on the line, but Clemens Steinbach, again, the director of the National Quality Center, is their coach at the moment, and he's going to be providing an update on what their process is in the Cleveland TGA and their efforts to end disparities. Thank you, Clemens.
Hi, everybody, and you probably figured out that I'm not Kate nor Melissa Rodrigo, who I want to acknowledge here. Just wanted to be sure that there is a big snowstorm going on in Ohio, so both of them are stranded, and they sent their apologies along the way in the area there where there was no reliable phone connection. I had the pleasure to actually work with the Cleveland TGA now for the last about 6 months or so, and they felt very strongly about building their capacity around disparities. And in one of their most recent quality management committee meetings, which I had the pleasure to be part of, the following decision was done jointly. The decision was that each of the sub-recipients in the Cleveland TGA was asked to actually take our EndDisparities tool and to actually run the data individually and come up with their own group and subpopulation of focus to determine which subpopulation out of the 4 that we have as part of our EndDisparities campaign is most relevant to them. So we conducted the training. We basically were all in one room, and we basically went through the tool. They were all basically instructed how to get the tool. We downloaded all the slides, which are part of our EndDisparitiesExchange.org website, to really give them the confidence to actually do it. The expectation was that by the end of this month, all of the subrecipients need to submit their data, and what we asked them to do is to basically send a screenshot of their results. In addition to the results, is also determine which subpopulation they believe, based on their own data, is most relevant to them. As you probably remember, all disparities are local. So and in addition to the data, which subpopulation, you need to tell in part of your reporting about what action steps, what improvement strategies are you planning to do as part of your strategies to use the data for improvement. This process is ongoing, and the deadline is very soon to submit the data. In the meantime, also the TGA-wide data was used to really develop their own TGA-wide data. And it was very eye-opening for many to actually see, not to use hunch, but basically use the experience of all the data sets we used to determine which population TGA-wide. So I think it was incredibly, obviously they are at the very early steps of their journey to work as a community, but I think it may be one example where rather than a central office, the recipient's office is doing the disparity work to really diffuse it further out and let the individual subrecipients determine using their own data. I think it builds capacity for looking at your own data. It also builds capacity to think about what data can tell you to set your improvement goals locally. So I'm going to probably end here, other than to say that this is really that Kate Burnett and Melissa Rodrigo who are really championing this idea, and I wanted to congratulate them for their hard work, gaining all the subrecipients capacity to really do this kind of work and educate them, and I hope that when we have our next meeting, which will be in January, hopefully there will be less snow at this point, to really report back. So if there's any questions, then Michael will tell me what the questions are, and I will be able to answer them.
Robert Bogle from Florida says, how do you suggest collaborating?
Hey, Michael and Clemens, it's Marlene. How are you doing today?
So Robert Bobo had a question from Florida. How do you suggest collaboratives be formed? Demographically, geographically, and I assume, Robert, that you mean, other lines too. Clemens or our folks from McPeak or Marlene and Shep, if you have any ideas behind this. Nanette, you too. What do you think here?
This is Clemens. Maybe I can give you my first hunch. I think this should be really more driven by affinity groups, and the affinity groups are probably the subpopulation you're working on. I think by looking at data very regionally, it's very hard to say that one part of the state should only address youth, for instance, or MSM of color. And I think I would take it more to the next level and try to figure out, is there an affinity, and really try to bring providers together who are trying to work on the same area and therefore share best practices. Because my assumption will be that the best practices for one group may be different than for others, and you want to be sure that there is the power of peer learning is utilized to bring the providers together of those that are working on the separate, on the various groups. I don't know if others want to chime in as well, but that will be my first hunch of a response.
Mm-hmm. Hi, Michael. This is Nanette.
Hi.
Hi. Based on my experience with, for those on the call, New York State had organized the state by regions, and it was to link and retain patients in care several years ago. And so I worked with Western New York that combined Rochester or Monroe County and Erie County, and it really became apparent as we were working through that the areas wanted to really work with each other. And so I think while not in every case, certainly in this case, it made more sense for folks to be organized, those that were in Buffalo and within that area, and those that were in Rochester so that they could meet more frequently and meet face-to-face. So the outcome of that is the organization, really, that evolved into McPeak. And so I think if Kim or Shari or Chantrell or Ashley want to make any comments about that, I think it really benefited them to be in a close geographic location with organizations having the same mission.
Yeah, I agree. This is Kim. I agree with both Clemens and Nanette. I think first you look at your data and let your data decide how it is that you need to move forward. And then once you create your objectives and goals, you're going to get an idea of how much of an area your goals and objectives will be able to impact, as well as who your partners are. So I think
please record your message. When you have finished recording, you may hang up or press 1 for more options.
I don't know what happened with that. Let me see. All right, I'll keep my eye on that.
So I think it's all of those pieces that were mentioned that's going to help you decide on how to move forward with a collaborative and how far you want your reach to be, realistically.
Great. You know, there are some other folks on the line here. I'm going to go ahead and unmute Julia Schluter's line. Julia, I know that you all in the Midwest Regional Group were working toward this, and I don't know if there's anything in your results or any thinking early on in terms of how you're trying to approach this as a team. And for folks on the line who don't know, the Midwest Regional Group involves providers in Missouri, downstate Illinois, Kansas, Iowa, and Nebraska. So it's a really big area. Julie, is there anything that you can share now, or is it too soon?
Hi, thank you, Michael. Hello, everyone. You know, we have our team meeting today in which we're going to talk about our results collectively. We aggregated our regional data, and we put that data into the Disparities Calculator. And kind of the data that we have seen is that we didn't really identify very many disparities as a collective group. And so in kind of talking about this and thinking about this, I think our next steps will be to take it back to the agency level and have each agency talk and identify their priority area, and then we'll be able to form hopefully some affinity groups based on those priority areas, work on and share strategies to tackle these identified disparities that we've identified at our own agencies. So I think that was one kind of lesson that we've learned along the way, is that perhaps our data is not as strong in terms of identifying disparities when you group all of these states together, because we're very different. Even in each state, each region is different. And so I think there's a lot of power in using the tool at a local, like at your agency level, and then being able to strategize with people in your regional group across states that are working on that same priority area. So that's the plan. We'll see how it goes this afternoon, but I am really excited in terms of being able to utilize the disparity calculator in a way that will create dialogue and hopefully stealing shamelessly from those people who have been successful in working on those priority areas that are common amongst different agencies across the different states that are represented in the regional group.
Great, and that sounds pretty much like a mix of what Clemens and Annette had said, that, you know, kind of looking at too big, you know, of an area, all of a sudden, you know, we regress to the mean, and it's really hard to see disparities. And, you know, I think that that sounds like a really solid next step. It's fun that while you were talking, Robert Bobo was asking another question, and you answered it for him. So thank you so much for that, Julia.
My pleasure.
So I see another. Go ahead, Annette.
Annette, I was just going to say, it also depends on what you think the nature of your problem is in your area, and how you might be taking next steps, and how far you would want to throw the net. So I think this takes into consideration how you define community. Mm-hmm. So are you going to be within your Ryan White community? Are you going to be similar to like what McPeak has done with expanding it to faith communities and to non-Ryan White funded programs and to supportive services? So if that's how you define your community, then that more or less is how you define your collaborative. Whereas if you're looking at statewide data and maybe specific regions within a state that you show some disparities, then that might be how you define your collaborative. So as Kim said, you go back and you look at your data to see what would be your catchment area, but with an eye as to where are you going to do your improvement work. Thank you.
Beautiful. Just a reminder that today's webinar is a 90-minute webinar, because the conversation that we're having now amongst the Ryan White participants, recipients on the phone, is one of the more value-added aspects of these types of calls, we believe. So we're really hoping that you're able to stay with us for the next half hour as we continue to discuss this Marlene, there has been some great conversation unfolding in the chat room, and I feel really badly that I cut you off before when you were trying to get at that awesome meat. I'm wondering if there's anything that you want to share in terms of what some of that discussion is revealing in the chat room now.
Sure, no problem, Michael. I think we're just really excited to talk about this, especially thinking about how we work across the walls of our clinic with other clinics. I think a lot of folks are interested in how do you, not only engage other clinics, how do you come to that, common understanding of what you're measuring. What I was thinking about, for folks who don't know me, I work at the HIV/AIDS Bureau, but prior to coming to the Bureau, I worked for a Part A program. And, we funded through the Part A program a number of Part C recipients as well as Part B subrecipients. And we just really felt like we had to come together in order to reduce burden. We didn't want to be reporting viral suppression, let's say, 3 different ways. And we needed to come together to share each other's knowledge. I think somebody else had commented on that. They just really wanted to learn from other folks as well. We have a couple of comments or questions that came into the chat room recently. I'm just scrolling up. It's very small text, so bear with me. Christine had asked, when addressing viral suppression, what are people's thoughts about it being adherence-related or related to social determinants of health or other factors? Christine, I think that's a great insight to think about when we get into this work. I think gone are the days where we have these, silver bullets or magic bullets to get at the problem or to get at the solutions, perhaps. And I think we need to think about these different things and what it's really related to. And I think this general project that we have here is having us think more about these things. Michael or Nanette, is there anything you would comment on that? You might be on mute.
I guess based on the work that some of the recipients have done with drilling down data, I think they find out that there isn't necessarily, other than putting into place a process whereby a group of multidisciplinary folks can look at the data and then look at patient-specific data, that we're at the stage now for most Ryan White programs, I believe, that you really need to begin to look at individual patients and what it is that they need. I think that what will be interesting about the work that McPeak is doing and their focus on a particular subpopulation is I think they'll be able to learn, is there in fact something different about, let's say, African-American women in their area that they could address from a systems perspective rather than looking at it at an individual level. So I'm really interested in how their QI work is going to proceed from here.
Yeah, that's really interesting. Somebody else in the chat room also commented that we heard folks in the chat room, I'm scrolling up to see, I think it was Sean Trail talked about how they're seeing some of these differences being more based in social determinants. We have Jenna's talking about it's a lot of housing stability, mental health, substance abuse, et cetera. Somebody chimed in that they see a lot of transportation issues as well. We also have Deanna from out in Oregon commenting on, maybe wanting to look into trauma-informed care and thinking about if that's something that they may want to consider and try out as an intervention. I think it goes back to, what we're hearing. I think generally, Michael, I'm thinking about a couple of things from the conversations that we had. I think, generally, teams outperform individuals. We know that. So coming together, I think we're stronger as a group than we are as individuals. And I think we're going to solve more problems together than we would individually. I think that's sort of a resounding theme for me from today. I think the getting started, I think you just got to do it. I remember when I was doing this and, I was in an NQC collaborative, and I think I just started picking up the phone and calling people, like doing cold calls to people who I worked with, in my surrounding area, and I just started having a conversation with them. And I was surprised by how few people, I think one person, wasn't really interested. Most people, I think, want to talk about these things because as you think about it, many of us who do QI, we're the only ones who do the QI at our agency. So we want to talk to other people who work on QI. And then I think going back to what I think Julia had said this as well as somebody else, you really need to see what's important in your own area and really focus on those things and have your local, your local environment really drive what you're working on. But, as always, these are really great conversations we're having, and I really encourage folks to continue these conversations in the chat room and even unmute your line as well. I'll turn it back over to you, Michael.
Great, thanks so much. And I had been trying to chime in too, but my line had been muted. I agree with all the comments that everyone has made, so I'm not going to go ahead and repeat them. But I think that this is a really inspiring conversation, challenging us to reconsider some of the ways that we traditionally approach this work. And the suggestion Marlene had made of just making cold calls as a way to start with this is definitely a good recommendation. One of the things that we did in Washington, D.C. when I was at Whitman Walker Health before the D.C. Collaborative started was to start to have rotating operations committees where folks who did operations and quality would come together to share their concerns and also to try to think about some next steps. And so, just an informal lunch, dinner, drinks club, something like that is a great way to, get that conversation going before it becomes formalized in your own workplace. So I see that we still have some conversation happening in the chat room too, so we'll come back to that. Since we're at 2:05, I don't know if it is too presumptuous if I go ahead and unmute Justin Britannic's line. I know that Justin in the DC EMA, which is a really big EMA, it includes the District of Columbia, suburban Maryland, suburban Virginia, and even part of West Virginia, so that's 4 states of wildly different culture and economy, they're starting to think about this too. And Justin, same question for you as I had for Julia. Is there any insight or anything that you'd like to share with folks today, or is it just too soon?
Hi, Michael. This is Justin. So yeah, there are a few things I do want to share. So one of the things that just kind of when we're looking at disparities, we wanted to give ourselves a little bit of time to really do a lot of planning, and I know that's something you helped us out with, is thinking about we want to make sure we're finding those root causes, ahead of time, and that's something we really want to look forward to as we go into this, is with all the data, and then also doing a lot of brainstorming, using our quality tools to really make sure we're targeting, the right things. Like someone said earlier, is it social determinants, or is it adherence, or is adherence a symptom of social determinants? Like really thinking and using the tools to try and find some of these areas before we get too deep into the project. And I could say for us, actually, it's kind of funny because it's a little bit of the opposite of, of drilling down and looking at, individual clinics. Because for some, they're already at 90% and they're, really advanced in quality, and it is just a handful of patients they can run through, Careware and generate a list of, a dozen or so patients and just try and work with them individually with, peer navigators or something like that. But also, like especially for the populations like youth and transgender, that when we roll them up to look at the EMA-wide picture, that's kind of, I think we almost see greater disparities when we look at them, instead of an individual clinic, when they get all rolled up there. So I think that's been helpful for us to kind of, not forget that whole picture and say, to be sustainable, we got to think more about than just a concentrated effort on a few patients at one clinic.
Great, thanks so much for those comments, Justin. Marlene, I've been seeing some more in the chat room. It looks as though there's been some offers and requests made. What's the recap?
Sorry, Michael, I was on mute. It looks like Sarah's going to be sending an email to Robert to talk a little bit more about plans and implementation. Robert says, well, I'm saying he says thumbs up. I actually think he said cool. You know, Kim is going to be doing some follow-up with Julia. So, you know, these are the things that we'd definitely like to see folks talking in the chat room, extending, you know, across the internet, the ability to reach out to folks. Because, again, I just like to emphasize, and I think Justin and Michael said this also, you know, we need to, you know, talk with one another, share with one another as much as we can. You know, the NQC motto is to share senselessly and steal shamelessly. You know, whatever we can do to help one another and improve patient health outcomes and ultimately improve patients' lives, I think is what all of this is about, and I think that's why many of us work in QI, because we get to see that all the time. We have Julia talking about some SPINS project work that's going on. Yeah, it's just been a really productive chat room here, Michael.
Fabulous, thanks. That's my sense too. So we have 20 minutes left in today's call, and I have a number of folks that I could continue to call out and see if they're willing to share. But I know that in addition to some of the people I work with a lot, there's some folks that I don't work with very much, and I'd love to hear your thoughts or impressions. You know, if you're already moving in this direction, what are some of the steps you've taken or the questions that you have? I invite you to unmute your line by pressing the orange button to the right of your name at this time. Or actually, you can enter in the chat room that you'd like to make a comment or that you'd like to share. That might be a better way to do it, since I've been informed by my colleague that you might not be able to unmute yourself.
I just want to note that Shari gave sort of a thumbs up or a shout out to using pivot tables, Michael.
Oh, fabulous. I love pivot tables. And if any of you are interested in learning a little bit about that and how it can leverage your work, drop me a line. Again, my name is Michael, and you can get me at michael@nationalqualitycenter.org. It's not that hard to teach, but it can really give you a wealth of knowledge to plug and play different types of information.
Somebody had mentioned, Tony mentioned something about an app, and I asked her if she developed it, but she said somebody else in the chat room had mentioned it, and I clearly missed that. So I'm trying to scroll up and see who that was. If you had seen that, Michael, can you talk about that? I'm trying to find that. I can't seem to find it.
Hey, Melanie, this is Chad. I think the question had to do with whether they could develop an app that would be sending messages to patients to remind them to take their medication, and whether that would interfere with HIPAA violations.
So I do know of it, and I'm sure, Michael, you have the same ones in mind, of grant recipients who actually are using text messaging within their program. I seem to recall, who was our friend from Detroit who works with the youth, Michael? I'm terrible with names.
Oh, Nikki Cochran.
Thank you. I know that they do a lot of text messaging, and she's done presentations at conferences about how they reach out to folks. So I would Google her if you're interested. I know that she's specifically one person who comes to mind who's done some text messaging. We also had, I'm trying to, it keeps moving. Ketlin asked, has anyone had an opportunity to look at the benefits of single tablet regimens on adherence and viral suppression? Due to insurance, some providers are running into difficulties with single tablets approved for their patients. I do know that there was a paper, I don't know what the citation was, but there was a paper within the last year or so that actually looked at that actual issue, and retention was higher. And Shari said definitely overall viral suppression has gotten better since the single tablet came out. So she might be somebody you might want to link up with and talk a little bit more. I might just say, Shari, if you're interested, you might want to just put your name in the chat or your email in the chat room to get folks talking. Michael, it sounds like somebody's interested, Robert's interested in pivot tables. He might be reaching out to you about that one.
Fabulous. And by the way, I have unmuted Sarah Schulbank-Smith in case you want to make a little plug for your app, or, you know, if you want there you go, or if you want to put your email in case folks are interested in continuing discussion after today.
Yeah, people can definitely email me. Can you all hear me?
Hi.
Yeah.
Hello, this is Sarah. Anyone can definitely email me at sarahss@howardbrown.org. I would be happy to talk more, but we are working on an app right now. We haven't actually launched the project, but we do have people using the app, and it allows you to see test results, and there are some countdowns, and we have the ability to send messages and also to receive messages from clients right now.
Great. I've seen some great presentations from your team, Sarah, over time, and you know, it's really impressive the work that you've done to advance this type of communication with patients. So that's really exciting. Thank you.
Thank you.
Hi, Michael. Can you put your email in again? I'm sorry, Nanette, to talk over you.
That's all right.
Sarah, it looks like folks are looking for your email address. You might be getting a couple emails, I think. I just wanted to acknowledge that Ellen from, thank you, Sarah, Ellen from New Jersey, and then also Alicia from Village Cares also talked about some text messaging work as well. So they may be folks that might want to unmute and speak up as well. I'm sorry, Nanette, did you want to say something?
Actually, it was because I can't type into the chat room, I just wanted to mention that there was a SPINS funded project that Dr. Lisa Hirshhorn did, and it was quite a while ago. She presented at the 2008 Ryan White Conference, and it was on enhancing access to quality HIV care for women of color. And I think it would be worthwhile for folks, if they're interested in women of color as a subpopulation, that they might access that and read it just to see what it was, what our findings.
Great, great. So folks, there was somebody, who was it, who asked if other folks are having any denials, insurance denials with a single tablet regimen. If you are, maybe you can make a comment and put your name in the chat room. So who was it? Somebody can follow up with you. I can't remember. I can't seem to scroll back.
This is such an important question.
Yeah, Jasmine was asking about that. So does anybody have an offer that you can give to Jasmine to talk about insurance denials or how to get it approved easier, if you found any sort of tricks of the trade, shall we say? I'd encourage you to put that in the chat room. Hey, Michael, somebody said the terrible words, multiple logistic regression analysis. Oh, my goodness.
I saw that too.
So we had somebody ask if pivot tables are comparable or better tool to see if health disparities as compared to using the logistic regression. All right, that's like way over my head, so I'm going to ask you, Michael, if you could take this one.
Yes, absolutely. And, you know, Shari is right on the money there as far as, you know, my understanding and capability, too, that pivot tables are really great to identify differences quickly that you might use as a leading question for further statistical analysis. So in terms of looking at a massive amount of data and quickly chopping it up into different slices and comparing those slices, awesome tool, you know, really, really remarkable and easy to use. But for those more complicated statistical questions, I think that, you know, using your standard analytic tools, you know, the SAS and the SPSS and other tools like that are still going to end up being superior for that statistical piece. So I don't know if you have any suggestions in terms of how you've done that work in the past.
So I will just say that the pivot tables are great tools. And in terms of understanding, when you're looking at statistical significance, you're really asking if it's like, you know, one group's 50%, one group's 70%, is that really different? And you can kind of get a gut feeling for this in looking at the number of people involved, right? Because if there's 10 people, it's probably not statistically significant. But if there's 200, yeah, it's pretty statistically significant. And so these statistical models, they're important, but I don't think they're really necessary. I think pivot tables are a really great way of just seeing your data really quickly, asking a number of questions, and getting an answer really fast.
Yeah, that's
great, thanks.
My sense too. Hey, Marlene.
Michael, I just noticed that a couple of folks have, I'm sorry, Michael, I'm just so excited about this. A couple of folks have commented on the insurance issue. Someone had noted, I think it was Sarah, noted that you can go through the patient assistance programs when you get denials from insurance coverage. Alicia also commented on the Medicaid SNPs as well. We also have, Catlin just wrote in saying that, you know, kind of like I hear you, Jasmine, they're having similar problems and they're working with their state health department to address these barriers with their Medicaid MCOs. That might be a way to go, you know, kind of working through the MCOs. And Jasmine's like saying a thank you. We just had someone come in. Samantha just said at their clinic they've been trying to use phrases about how the newer one pill regimens are safer long-term. So it sounds like you've sort of kind of coined some language that you're using. And if they're on a triptyl, the medication has been removed from the list of recommended medications due to the side effects patients have and the fact that there are safer meds out there. So it sounds like you might have a couple of ideas, you know, kind of using some, you know, real specific language, as we heard from Samantha, maybe talking with your state Medicaid or state health department to help you get to the MCOs to address this even more. We also had somebody talk to, you know, suggested talking with ADAP to see how they can get the medication covered if that's how the patient is getting their medications. That's a good idea as well. Thanks, Ashley.
Beautiful.
All right, Michael. I think I'm up to date on the comments.
No, thank you so much for staying on top of it. It's another active chat room. Last month and this month, the most active chat rooms we've ever seen, and we really appreciate all of your attention to this and your focus here. Alicia, you know, back a while ago you had mentioned a texting program, so I wanted to mute your line just to give you a chance to talk a little bit about that and maybe share your email.
Hello?
Hello.
Hi. Yeah, I don't actually work for Village Care or the program. I work at a managed care organization in New York, but that's the program that we refer all our members to. They need to have a working cell phone, but I know that when you said that, and you're like, can you do that? And I was like, oh yeah, you definitely can do that because it's a very popular program and has definitely helped some of our members who their issue is just, you know, I like forget, I can't remember. I don't know if that's specific just to New York, but I'm gonna include my email, and if that sounds like something that, you know, someone is interested in, I can put you in touch with the point of contact if you want to learn more logistics about that program. Is what you're asking about?
Beautiful, absolutely. You know, and for everyone who's registered for today's call, there'll be a copy of the slides, a copy of the recording, and a copy of this chat transcript sent sometime tomorrow when I'm back in the office. So, Ellen, I unmuted your line as well because you're another one of my friends and colleagues here who is in it to win it. And I know that New Jersey has had years and years and years of experience working as a collaborative. You're a huge, densely populated state, with that's small geographically, but has big differences depending on regions. And I'm wondering if maybe you could talk a little bit about the path that you're setting for the team in New Jersey for this work, or if it's too soon for that.
It's funny. It was we had our meeting, our quarterly meeting on Monday, and this was a big discussion in regards to where we're going with this because of, as you stated, we're very densely populated. We have a high population of HIV in our state, but there are big differences around the state. So what is an issue or a disparity for a region is not necessarily it for the entire state. So essentially, we've picked it apart that we think that everybody's going to focus on what is in their region. So for me, when I wear my hat as the Part D grantee for the state, we know our youth, 19 to 24, are the biggest issue, and actually we're the pull down for the viral load suppression in the entire state, and I know that, I own up to it. But at my 7 clinics, we have the largest youth population in the state, so we account for the majority of it, if not well greater than 50% of it. So we have been focusing all along, and that's why I chimed in with our text messaging, is that my programs, we got supplemental funding, and we were doing a peer-to-peer mentoring. So Great. We, trained a peer to work with a non-adherent youth who hopefully that connection will yield somebody who's retained in care and virally suppressed within the year. So we are utilizing the texting and with the peers with each other, as well as there's a mental health provider or a medical case manager that is working also with the pairing at each clinic in our state. So we went through a lot of training and HIPAA training, and we made them sign off and discuss how to use the text messages, how to delete the text messages. It's all confidential. You don't, discuss this anywhere else. So we're end up doing the disparities. So the long and the short is it's depending on the region of the Part A or the Part B group, or the funding stream that's going. Because in most of our states, we have the whole northern part of our state are Part A's, and then the southern really ends up being in the Part B funding stream. Does that help, or is that totally confusing now?
No, it demonstrates the many different ways that we can think about this depending on our own needs. And what I'm hearing from all of our presenters, our friends at McPeak, Clement's presentation from Cuyahoga, Justin's discussion of DC, Julia's discussion of the Midwest, and your discussion of New Jersey, is that it's an individual pathfinding mission where you bring folks together first who have interest and are dedicated to this topic, and just to start to find where some of those similarities and differences are. You can have that initial conversation in the presence of data, which is probably helpful, but you don't necessarily need the data if the data is not ready yet, to start thinking about these larger moving pieces and how we interrelate with each other, the ways that we interrelate with each other, and how we can leverage that to really make a difference in people's lives moving forward. So thank you, all of you, for all of your presentations today.
Well, in New Jersey, with us being in the H4C, we were looking at disparity data anyway. And then with Pat doing the disparity calculator, we already had our data put into it, and it came out with exactly what we knew, is that our biggest disparity is the youth.
Yeah.
So that, just further defined what we knew what was happening all along with our data in New Jersey. So, everybody was at the table through this whole discussion, all the Part A's, the B people, and the state, as well as other clinics outlying.
Great. Well, with 3 minutes to go, Nanette, perhaps you can summarize the thought on this slide for us and bring us home.
Oh, my gosh. I just got out of the slides. What does it say, Michael?
Oh, I'm sorry. This slide is the what is realistic slide. slide. What is realistic? There's a difference between a collective team level and an individual CQM team at a Ryan White provider agency. You know, and the picture here, I think, is very simple, but again goes at you know, what we normally think of. That individualism, you know, is kind of inward looking, and we're trying to create a collectivist approach here that is outward looking. And I don't know if you have any other thoughts on that.
Well, just that I think to bring it back to the beginning of what we were talking about, Michael, in terms of the real importance of defining who your community is. And, you know, Ryan White providers are so complex in terms of whether or not it's an A or a B or an individual agency, so that that one team, though, whether they're trying to look at viral load suppression and increase their linkages throughout their organization, if it's in a hospital, it's more complicated because they might want to pull in the emergency department and other staff members from other parts of the hospital to, you know, larger Part D networks. I was working with one in Western Massachusetts, and Holyoke Health Center is one team, but then they subcontract with Bay State Health that has 4 subcontractors with them, and then there's another health center. So there you have quickly 6 or 7 teams that are involved with that one Ryan White provider. And then you have, you know, regions of your states and facilities that are agencies that are within a community like Monroe County and in Rochester. So it's all very exciting, and it's all very creative, and I think that there's so much room for people to really experiment and share what it is that they find that's working.
Thanks so much, Nanette, and thanks everyone for all of your attention and for a great discussion today. You know, on behalf of the National Quality Center, you know, we really think that this is one of the most important ways that we're going to attack this question, and it's been impressive to see the work of the Ending the Epidemic Task Force and that Blueprint Committee, and then how that has kind of reflected through communities in New York State to really push and challenge teams to think beyond just what we normally do. And, you know, I'm really grateful for the McPeak team and for Clemens, and then also for Justin, Ellen, Julia, and others who shared their story with us today. So thank you so much. Please fill out that evaluation. That should be landing in your inbox momentarily, and be on the lookout for the chat transcript and slides and the recording tomorrow, my friends.
And thank you, Michael.
Thank you, Michael.
It is my pleasure. All right, everyone. Have a wonderful day. Thanks for all you do.
And wonderful holidays.
Oh, yes. Happy holidays.